alaikum. Good morning, everybody. So we will start with the case to introduce the talk. And the case is a 70-year-old lady with multiple surgeries. She had the 2008 is the tissue valve to the tricuspid, and done in another hospital, not in our center. So we failed to find the report and the details of the surgical and the brand and the size of the valve done at that time. The second surgery done at 2000 with mitral valve and aortic valve mechanical both. The LV function is normal. The patient is in atrial fibrillation and well anticoagulated. And the patient being following with his cardiologist for quite some time. Then came back with the decompensations after the degeneration of the tricuspid bioprosthesis with repeated admission for the right side heart. And there was a history of ascites being tried to do TAB, but complicated by the hematomas and bleeding requiring blood transfusions. Then the patient discharged after that for the follow-up, then readmitted again with the same presentation, right-sided failure. At that time, the time of bleeding, there was a bleeding fizzle. It was embolized and stabilized. Patient hemoglobin after that stayed stable, and the echo showed severely degenerated tricuspid bioprosthesis with both stenosis and regurgitation. And the CT was done to plan the size of after the discussion in the heart team. So the patient has the option of transcatheter therapy. And for that, we did the CT scan, plain CT without contrast. And this is his heart CT. Yes, I will leave it for Dr. Anas to analyze the
next
CT.
slide, yeah, the Abdulrahman, okay, next slide. Yeah, okay. Smart screen, please. Okay.
Surgical risk with a double mechanical valve in the aortic and mitral position with a tissue bioprosthetic valve which seems to underwent structural degeneration, and it followed kind of the expected timeline for that. I'm not a CT radiologist, but these are the CT images of this patient with the highlighted measurements. And you can appreciate here that the average measurement, and I'm going to go through them, is anywhere between 2.3 to 2.4 centimeters on average. Okay. So just to highlight a point is that when these are looking at the true internal diameter of the valve, each bioprosthetic valve has an internal diameter and has a stent-to-stent diameter. So the stent-to-stent is the actual size that's reported by companies. What we are measuring by CT is the true internal diameter of the actual valve. So that would be the inner edge to inner edge. In this patient, it's around 2.4. We have a tissue valve, so that could be, probably a size, maybe a mosaic size 26, 27, who knows. But generally, these valves can accommodate, probably like a sapien valve within the valve. Yeah, we can keep going.
Okay, thank you, Dr. Anas. So we'll go to the panel, see what their opinion about this case. We'll start with Dr. Sundus.
Okay, so as he mentioned, Dr. Almoghairi, that the patient is with multiple medical problem, and even simple ascitic tap caused significant bleeding requiring some intervention in her. And the CT is encouraging to have maybe a 26 valve, as Dr. Anas mentioned. So going an option in this patient with a valve-in-valve consideration looks like a very feasible option, because other option wouldn't be like that's great in her.
Dr. Hajji?
Yeah, I agree. I think valve-in-valve is potentially the best option for this patient.
Dr. McKenzie?
Yeah, I would second that. Not much to add. I think it's pretty straightforward and probably amongst all options the best one. It's quick and the patient will have a quick recovery.
Dr. Belghaith?
I think I will agree. Valve and tricuspid, we done it a few years ago, and I think one of the easiest if you do it rightly and the fastest procedure in the cath lab.
Dr. Zakaria?
Yeah, she's a high-risk patient, and she is suitable for valve from imaging point of view. So I would agree with the...
So from surgical point of view, I think she's a good candidate for valve. I don't think she's a good candidate for surgery. Fadal, Dr. Abdulrahman.
Back to the
So
presentation.
So we went back and then we plotted to the application and we did from the application to calculate the valve. The valve 24 millimeter diameter is consistent with size 26 Edwards or 24.5 by Merrill valve. So we went for the 26 valve. With the oversizing based on the application is about 17%, which is acceptable, and we have up to 25% oversizing is acceptable in this kind of cases. And the valve, it looks Magna 25 from the X-ray looking, and maybe our measurements is it's good, it's in this range. So the pushing the valve, as Dr. Balgheth said, is not difficult. It's does not need any like the transeptal for the mitral. It's just the aligning the valve. And to give the support, we advanced the wire, the regular wire, either Teromo or usually it's Teromo to one of the pulmonary arteries. Then with the diagnostic or guide catheter to deliver the stiff wire or the extra support, whatever the wire available in the lab can be used. And then advance the valve. Once the valve is in position, you cross the valve, then you don't need the pulmonary support anymore. So just either direct it to the apex or get it back to the delivery system to keep stabilization, because you need the pulling back, not the pushing forward for during the application or during the inflation. Because once the balloon inflated distally, start the balloon inflation for the mitral or tricuspid, do the same. Just tension back to the system to achieve the 10% protrusion into the atrial side. And this applies for both, for the tricuspid and the mitral. And the result was good after that. And, the gradient, as you see, is 4. There is no paravalvular, and the patient went home in a good condition with expected follow-up in the clinic. And now I will go to offer the evidence for the tricuspid valve all over the years. So the valve, usually we lean towards as a cardiologist, we lean towards the delaying the surgery for the isolated tricuspid valve. But once we send the patient for the repair or mechanical, so the comparison between the repair and the surgery and the valve replacement, maybe the repair is preferable, though the outcome is at the end is the same, because the repair is associated with less re-intervention, and the survival at the end they catch each other. And also in the term of the background, the baseline pathology, is it functional or structural? The outcome is the same. Did not change the mortality. So the outcome is based on the severity. It's not the pathology which brought the patient to seek medical advice. And as compare the repair versus surgery for the primary pathology, so did not drive the outcome. What drives the outcome is the patient presentation. And in terms of comparing the mechanical versus bioprosthesis, yes, mechanical is more durable, but the drawback is the thrombosis. Thrombosis is higher with this one. That's why the physicians lean towards the bioprosthesis more than the repair. And the analysis from different trials did not show much of differences between the two in the term of the outcome, but the main drive is the events. And also in the term of the repair, so is the band or soft ring like the Divega or even the Duran band. It's not the best option. Probably nowadays they prefer the stiff ring or the complete ring to help in the future intervention if the repair is the option for those patients over the replacement. As from the cumulative evidence. And from our lab, we compared it the same. We came with the same result. The rigid ring or the complete ring is much better than the band. And in terms of survival, readmissions, the heart failure, reinterventions, it's almost consistent. And also recently comparing the outcome with both tissue versus the mechanical and tissue versus the repair, it's also consistent with what's being documented, and this is from our lab. The transcatheter therapy itself, it's associated with good outcome. Yes, the long term is not, it's still pending, but I think it's the available evidence. The mortality is favorable, though the risk of the procedure itself is very high. The intervention itself is associated with the 30% risk if the patient is going to redo surgery, and the transcatheter maybe the risk is lower, but still in the range of 10%. And what they can get from the available evidence is the improvement of the symptoms. And also the consistency over maybe the maximum follow-up. You may see it in range of 1 to 2 to up to 5 years, but is still it's valid. And also the 1 year from the other study also is consistent with the symptoms, sustainable result. And in our lab, we started from 2010, the valve and valve, and now from 2017 until 24, we did about 25 cases. Still, we did not report it. What we report is the initial experience in the 2010. But the new data probably we are working on it to be published soon, inshallah. And the second case is not the CT based, is the application based. It's similar patient with the comorbidities, the multiple surgeries, and the patient came back with the degenerated valve, but this time the valve is known. It's a Magna 27, and because the patient had same scenario consistent with the studies, the initial valve was mechanical, then redo and replaced with the tissue, and the tissue now is degenerated, and the patient landed in the hands of the interventionist, and the heart team also supported the going to the intervention within the term of the valve and valve. We use the application for that. And we use the Sabian 29. The visualization of the valve is very difficult because this is the beauty of the hybrid lab. The hybrid lab, they use the Mackay table, all metal. So whatever projection you try, but we managed to get at least the imagination of the alignment of the valve. And we get the wire to the pulmonary artery as usual, and we managed to get the valve across the biprosthesis. Once in a position, we pulled the wire because the wire did not help us to stabilize. You will push the wire forward, but it will push the valve back, so we take the wire out. And we kept the valve in position, and we deploy it nicely. We achieved the 10-15% protrusion into the atrial side, and the result was good. This is a Sabian 29, and the patient is following in the clinic and is good. The conclusion from this is the natural history of tricuspid valve disease is not benign, and the severity and symptoms is the driving for the prediction of the outcome, and the and not the mechanism of our etiology of the valve disease. And the early intervention probably is associated with better outcome. And the repair is superior to the replacement, and the transcatheter option, once the valve is degenerated, either the ring or the fibrosis, is safe and feasible. And thank you.
Thank you, Dr.